Hello, everyone. I'm Dr. Marty Ross, and it's another conversation with Marty Ross MD tonight. I know I have not been with you too much lately. I had a busy month of traveling last month. I had to give a number of talks across the country and get to take care of my demented dad in his assisted living facility. So that pulled me away, but I actually will be with you a lot in May. I have five webinar scheduled for May, including tonight. There is a change in the date of next week's webinar. Instead of doing it on Thursday, I rescheduled it to Wednesday this morning. And the reason is I've got a dear friend of mine that's coming in from out of town, and Thursday night is the only night we can get together. So I'm going to make room for him, and I'm going to move next week's webinar to Wednesday. All right. So the way these webinars work, you create them. You create them with your questions. And how you get your questions to me is write your questions in the chat box. And when you write them in the chat box, make sure that you write them to everyone. So you have an option of who you send it to. Don't direct message me. I just see that one person did that. Try not to direct message me. Actually send it to everyone. And the reason I want you to send it to everyone is that others can see the question. It's easy. Some people like to hear me read the question. Some people like to follow the question in the chat box. Okay, so that's the reason for that. It'll be interesting to see what happens tonight because we've got a low sign up tonight, and I think it's because of my not being so available last month. If you don't show up, things kind of fade. So those of you that are here may have quite a bit of opportunity to ask questions. I also realize it's the beginning of the webinar tonight too, so we'll have to see if more people show up as well. All right. So the other thing is I am creating a recording of tonight's webinar, and I will send out a notification to you tomorrow. You'll get notified on the Lyme United platform when I have posted that. And usually I post it somewhere between 9 and 9:30 a.m. And that is what my plan is for tomorrow as well, too. All right. So without any further ado, let's go ahead and get started here. So let's see. First question we'll take is from Meg. Hi, Meg. So Meg says, greetings. What can you tell me about Bartonella nodules, treatment, and length of time? It's interesting. So Bartonella nodules is a symptom, an effect that you can see with Bartonella. And they're literally little bumps that you feel underneath the skin. They feel like little nodules underneath the skin. All right. And why they happen, I don't know that we fully know why they happen. What I can tell you is Bartonella likes to get into what are known as endothelial cells and into what's known as connective tissue cells. So endothelial cells would be cells that line your blood vessels, for instance, okay? But then connective tissue would be things like collagen and the tissue that runs between your cells, and also the kind of tissue that makes up your tendons and your ligaments and your joint connections, basically. And it may be that what we're seeing with these nodules is that it's due to inflammation within the collagen and connective tissue where Bartonella likes to live. So it's kind of an inflammatory reaction. What I have seen in my practice, and I will tell you, no one studied this. You can't find any studies on this. Okay, so I can only reflect on what I have seen in my practice over the 20 years or so that I did this, that I was treating people clinically, is that usually as you get Bartonella under control, over time, the nodules will go away as well too. They will go away as the rest of your Bartonella symptoms are starting to resolve, okay? And again, because I think, and this is my opinion, I think what they are is an inflammatory reaction within the connective tissue where some Bartonella chooses to live in some of us, basically. All right. Now, it'd be interesting. I don't know why they occur in some people's Bartonella and in others people they don't. I have no explanation for that. But that's the kind of thing we see with any of these tick-borne infections, in that how they present in individuals, there's always a unique presentation in some individuals versus another. And I think it has to do with just our immune systems are set up entirely differently. Even though we're all humans, we all operate a little bit different. The environments we live in are a little bit different. Our genetics are all a little bit different. And so we do get different expressions. But yeah, I would say maybe I've seen nodules in about 5, maybe 10% of my Bartonella patients. All right. So on the timeline for Bartonella, for about 80 to 85% of people with Bartonella, that have not been treated for Bartonella before, 80 to 85%, I think we can resolve Bartonella within 4 to 6 months of treatment. Now, that is probably not the experience of this group here because there's that 15 to 20% that the standard treatments we do not seem to work in 4 to 6 months. And so, our group here is going to attract those people that standard treatments don't seem to work as well for, all right? But for about 85% of people, it's about 6 months and you should get resolution. If you have not gotten resolution in that time doing a pretty thorough treatment, then it could take a year, 2 years or more to get it resolved. Okay. So Meg, did that answer your question for you? Oh,
Best
yeah.
treatment.
What now?
Best,
best
treatment.
So are you an herb person or a prescription antibiotic person?
Oh, we're never doing both.
You'll do whatever. Okay.
I would rather switch. Yeah.
Yeah. So on a prescription side, my favorite go-to prescription remedy for Bartonella these days is a combination of a compounded medication, meaning it has to be made by a compounding pharmacy called methylene blue, along with diflucan, also known as fluconazole. So fluconazole you may know of as something we use to treat yeast and fungus infections, but there is laboratory data out of Johns Hopkins that one of the family members of fluconazole called clotrimazole was just whoppingly effective in the lab at killing both growing and hibernating or persister Bartonella. And so many of us decided that if we couldn't use clotrimazole because it's only available in creams, that maybe we would start using fluconazole instead and had good results with that. And then methylene blue is a drug that's been repurposed to treat Bartonella. It's actually designed to help people with a blood condition called methemoglobinemia, where they're under stress, their oxygen is not let go of by their hemoglobin and they literally turn blue, right? But anyhow, it helps bump the oxygen off in those situations. But we know from the same Johns Hopkins lab that looked at fluconazole that methylene blue is great for 3 reasons. One, it kills growing. Two, it kills persisting or hibernating Bartonella. And three, it actually breaks up the biofilms that limit Bartonella treatment as well too. Okay. All right. So on the prescription side, I like that. On the herbal side, I like using a combination of Cryptolepis at 2.5 milliliters 3 times a day, along with Japanese knotweed at 30 drops twice a day, and then a combination pill that has cinnamon, clove, oregano in it. There's a company that sells it as liposomal cinnamon, clove, oregano essentials, for instance. And those 3 herbs are great at killing growing and persister Bartonella, and they also have benefit at removing the biofilm. So they kind of mimic what the methylene blue does. As to what's better, I think, in the prescription side, I would think that, in my experience, I give the fluconazole methylene blue about a 5 to 10% greater chance of helping a person. That's not to say you wouldn't be one of the people that 85% that the herbs work into. Okay, it all depends on who you are, basically. All right. All right. So you can find both of those. If you look at my how to treat Bartonella article, I can show it to you here real quick. You'll find I have a box in the middle of that article that basically says, here's my favorite prescriptions, here's my favorite herbal remedies. Okay. And actually, I'll just show that to you here real quick. Let's see here. That looks good. Share. All right. So if we go over to my Lyme information site, this is it, the Treat Lyme by Marty Ross MD. And I'll just write Bartonella in here. Let's see. So my Bartonella article is called The Ultimate Bartonella Treatment Guide. Okay. And in here I talk about various things you want to deal with to get rid of Bartonella. But if you go all the way down here to this box right here, this is where I say best herbal combination, best prescription antibiotic combination. Okay. All right. Any other questions on that? Okay. Does anyone have any questions on that? I'll open it up for other questions. Again, when I open up for questions, it's only about the existing question we were talking about, not a new question. Okay. All right, let's see here. Let me go back to the chat box then. Good luck to you, Meg. All right, let's see here. Hello, Chris. Let's see. Hi, Doc. First, should I treat my daughter who has had the bullseye but no symptoms? It has been a few years now. I feel beyond terrible for if I knew then what I know now. Tell me more about your line of Senolytic products. Which ones are best for what symptoms? Thank you. All right. So, so first of all, somebody's got their microphone on here, and I'm going to mute them. So if you see yourself suddenly being muted, I did that to you. Okay. And that's so that I don't hear your sound. Sandra, I see your hand up there. Let me take the question from Chris since I started on. I'll come back to you here in a minute. Okay. All right. All right. So that's a good question, Chris. So the reason I definitely would treat is if you actually saw that there was a tick attached and then the bullseye rash developed afterwards. Okay. And the reason I make that distinction is it's possible that things like spider bites and other things give us bullseye rashes as well too. Okay, but what is diagnostic for Lyme disease is if you have a tick attached that you know of, and then there's the development afterwards of a bullseye that is diagnostic of Lyme disease. Okay, um, now the issue you're going to run into is if she has no symptoms and it's a long time since that happened, even if you know there was a tick attached, do you do anything about it? And I kind of err on the side of not doing anything about it, but that's my opinion, and I want to explain why my opinion. Okay, all right. So it is very possible that our immune systems can eradicate the infection. It's possible. All right. Now, when you participate in a group like this, you're going to think, no way, everyone here is sick with this thing chronically, right? But I want to let you know, yes, it is very possible that for some people that their immune systems deal with this. And dealing with it can either be wipe the germ out, or deal with it can be hide that germ away in a way that the immune system has got it under control and it's not going to bother the person. Okay.
Mm.
So the reason I choose not to treat in those situations is if you were to treat, you're going to wind up. Oh, and then the third thing I want to raise here is we do not have a test that tells us that we got rid of all the germs. Right. So we have no endpoint at which we can treat. So if we've got somebody with symptoms, an endpoint can be they got well. All right. Or they got well and we can't do anything more, but they got a lot better. All right. That's an endpoint. Okay. Another endpoint is if you happen to have a test that tells you you're done, well, you can test for that. But the problem is when somebody doesn't have symptoms, you can't use symptoms as a guide to stop. And because we don't have a test that truly tells us we're done treating, you don't know how long to treat for. Okay. Right. But then the bigger issue I have with treating when somebody does not have symptoms is the reason you're always weighing out risk and benefits of using herbal and or prescription antibiotics. It's a risk benefit ratio, right? So the risk of using either prescription or herbal antibiotics is immediate side effects. But the second big risk is some disturbance to the gut microbiome. Now, prescription antibiotics have a greater chance of disturbing the good bacteria that live in your intestines, but herbals can do it too. And we are increasing, if you were to look at the amount of research that's going on in the gut microbiome, like what does it do? It's gone up exponentially in the last 5 to 10 years. It's just taken off. And we now know that basically you could make the argument that the gut microbiome is the brain of your brain, is the brain of your mental health, is the brain of the immune system, is the brain of how your gut works, is the brain. I can go through every system in the body, but the metabolites that come from healthy functioning microbiome direct all of our systems in the body, right? So over time, and I will admit, I went 20 years ago, I used to use antibiotics in this kind of a situation. But as the science started coming out more and more about the importance of the microbiome, and because we don't have testing to prove we're done, and because I think there's a chance that some of us, our immune systems wipe it out or keep it under control, I tend not to treat in those kind of situations. Okay. All right. Now, if you talk to another Lyme doctor, they may have a different opinion. And what I want, we have no science to guide us on anyone, right? But I want you to know why I have that opinion. I think I got that for you. Okay.
Totally appreciate it.
Yeah. Do you have any specific questions about that part of your question? I'll go on.
No, that makes total sense. I appreciate that. I mean, I've heard you speak the similar words many times, different ways. So
Yeah.
yeah, just
Yeah. Okay. Okay. All right. Then Senolytics. Let's talk about what Senolytics are. So our cells have a limit to the number of times that they will divide. Okay. And I think it's 250 times they're set to divide. And when they stop dividing with this natural limit, they turn into what are known as, they go into senescence, cellular senescence, meaning they've stopped dividing. And when they're in a senescence state, they start releasing a bunch of cytokines, inflammation cytokines. They're not no longer doing their regular cell function. They sit there and still take up space, but they become highly inflammatory. And that inflammation then spreads to the other cells around them, and you just get this cytokine inflammatory mess, which, if you have chronic Lyme disease and you've got a bunch of cells that are kicking out cytokines, you've added to your excess cytokine load that just having those infections. Okay. All right. Now, as I said, there's a natural limit. And so when we first discovered these things called senescent cells, it was always thought to be related to they reached their normal cycles that they could replicate. We now know that things like oxidative stress and the effects of toxins can sometimes stop those cells from dividing too. So it's a different reason they stop dividing, but they stop dividing. Okay. And so when they stop dividing, they become these big factories for cytokines. So what I have been recommending these days as a result of that is periodically using what are known as senolytics, herbs or prescriptions. There's one prescription that can do this, but it's actually an anti-cancer medicine, so it's kind of I wouldn't use it. But the herbs that are shown to be senolytic, the strongest one is an herb called fisetin, and that's one of my senolytic offerings, and the other one is quercetin. There have been studies done, God, I forget what kind. It was a cancer situation, I believe, where they used a prescription called doxorubicin, I believe, or dosatinib. I think it's dosatinib, along with quercetin in their protocol. And their protocol showed that if you do, I think it's 3 days in a row, both those drugs, and then take like 14 days off, that seemed to get rid of those senescent cells. And what happens is using the dosatinib along with the quercetin changed receptors on the covering of the cells so that the immune system would now see this as something to get rid of, basically. All right. Right. So because of that one study that was done, now when you look at what is recommended for senolytic regimens, it's based on this few days on, 2 weeks off kind of regimen. So there are no studies that tell us what is ideal in humans to do with a fisetin or a quercetin. But you could either choose fisetin by itself, or if you really want to be stronger, do a quercetin and a fisetin. And the way I would do it is a couple pills. So fisetin, I believe, is a 500 milligram pill. So I would do 2 pills once a day, along with quercetin, 500 milligrams once a day. I do that 3 days in a row and then stop. What you might notice is that you flare up by doing that because your immune system now is going to come in and kill those cells, right? So I think it's something, and again, we don't have science that shows this works in Lyme disease. Don't get me wrong, but I'm always looking for what is that thing we're missing, all right? So I think it's a good idea for people that are 2 years in their treatment and they're just stuck, or they got 3 years in their treatment, got a lot better, and then they become stuck. I start wondering what else is going on. And one of those things that could be going on is having developed these senescent cells, basically. So I hope that answers your question then too.
perfectly. Yes. Thank you. That's
All
all.
right.
That's
Yeah.
awesome. Thanks.
Yeah. Good luck to you. All right. Let's see who had their hand up here. I thought, I do see yours, Tracy, but let me see if there's any. I thought there was somebody else that had it up earlier. Anyhow, all right. So Tracy, go ahead. What do you got?
So would that be a kind of protocol you could use for long COVID as well? Is that where they're trying, is that the same sort of like mitophagy kind of thing, getting rid of old cells?
So that would be a way of getting No, it's a little, I'm sorry, that's different than autophagy and mitophagy. I'll say something about that in a minute, but could, as a result of having COVID, all that oxidative stress, is it possible that one of the reasons people remain sick and inflamed, could it be because the germs caused cellular senescence in a variety of cells? Yeah, it could be. I haven't seen any research that tells us that, but in theory, it could be, okay? What you're talking about is a different aging process that can occur, and that is where our cells and our mitochondria lose the ability to do something called autophagy, or when it occurs in a mitochondria, we call it mitophagy, which is our cells have the ability to recycle damaged parts that aren't working anymore. All right. And that's a process, and some people call that cellular rejuvenation or mitochondrial rejuvenation. But basically, what you're doing is you're letting the cells cannibalize, if you will, proteins that are folded incorrectly, enzymes that aren't quite structured right, things that they kind of just park in there and they don't do anything with, but are taking up space and aren't working well. Okay. So the way you can induce both mitophagy and autophagy, which is autophagy means cells that do this. The best way I like to do that is with a fasting mimicking diet. If you fast for about 2 to 3 days within a 5-day fasting mimicking diet, you enter a phase where, because of nutritional starvation, if you will, your cells start cannibalizing the existing parts to repackage them to use them again. Okay. So, as many of you know, I've talked about this Prolon fasting mimicking diet before, which is a type of diet that supplies you about 700 to 1,000 calories a day, depending on which day in the 5-day fast you're in. But they supply you also with an essential amount of amino acids and an essential amount of fats and an essential amount of carbs, so you don't start destroying your muscle mass at the same time. Okay. Because the problem with you don't want to destroy muscle mass. You want to keep your muscle mass. All right. But a Prolon fasting mimicking diet can do it. Another thing that can induce autophagy is hard exercise. I mean, I want to advise, hard aerobic HIIT training for people that are in the middle of a tick-borne infection treatment. But I want to let you know, HIIT training, for instance, can trigger autophagy as well too. And then there's a herb called Spermidine, which is a chemical that comes from various beans and legumes. Soy, for instance, has spermidine in it. And spermidine also triggers autophagy as well too. And the way I recommend doing that is somewhere between 8 to 12. I'm sorry. They come as 8 milligram pills, and I would do those as 2 or 3 pills one time a day. You just take that continuously. You don't do that on a start and stop basis the way you deal with these senolytic cells, these inflammatory, they've stopped dividing cells. Okay. Cells that have all these parked parts that they aren't using still divide. They haven't stopped dividing. It's just they've accumulated a lot of garbage inside that kind of sludges up the functioning of the cell, if you will, basically. So you can through autophagy get rid of these and recycle these parts that are parked in the cells.
Great, thank you.
Tracy, did that answer it for you?
Yeah, yeah.
Okay.
Definitely.
All right. So I'm going to do a screen share here because I have an article that I've written about longevity, what's called longevity, living life longer, and health span, which is living life longer, but living healthier while you live life longer. Okay. So there's a bunch of growing field now is that we got all these aging people in an area called longevity and health span medicine. And I've been studying a lot of that. Actually, it's an area of particular interest as I'm going to be 63 here in a few days, but but it really has. It personally has sparked my interest. And as I've looked at these articles and have been learning stuff for myself, I've been trying to bring some of those ideas here to all of you too. All right, so let me show you where you can find the longevity one. So there's this article called Longevity Interventions for Chronic Tick-Borne Infections and Mold Toxicity. Okay. And this is where I talk about things like cellular senescence, autophagy, etc. Okay. So read through here, you'll see what my ideas are. And I do want to let you know, none of these ideas are actually researched for tick-borne infections or mold toxicity. I do explain to you why I think they may be involved. A lot of these ideas are involved in tick-borne infections. And most of these, again, are ideas I would look at if you're at that, 2-3 year mark and you're not making any headway. I want to start thinking about other things that are going on, like are your cells all clogged up with garbage? And do you have a bunch of inflammatory non-dividing cells? Okay, that's when I start wondering about these ideas. Okay. All right. Any other questions there about that topic? All right, let's move on here. Hello, Cecile. Let's see. Hello, I'm Cecile from France. Hello from France. Let's see. When we start an herbal protocol for Lyme Bartonella, should we expect a significant improvement in pains within the first 3 months, the first 6 months or longer, or should we change the protocol? I started a protocol for 6 months and I just felt a low improvement after 1 month and a half, but since then, nothing. Okay. So let me try to answer. I'm going to try to answer this in what we can expect in a Lyme and a Bartonella treatment, and then give you some ideas of how do you tease out what might be not going right from a Bartonella or a Borrelia standpoint, Borrelia being Lyme. Okay. So Bartonella, as I mentioned earlier tonight, if you're on a treatment that is effective, you should start seeing some improvement in those symptoms. If you're on prescription protocol, usually within a couple months, and if you're on an herbal protocol, somewhere between 2 to 3 months. Bartonella specific symptoms, and I'll try to review what I call Bartonella specific symptoms with you in a minute, okay? All right. On the other hand, so if by 2 to 3 months you're seeing no improvement in Bartonella symptoms, then you need to think about changing to a different Bartonella killing regimen, okay? Now, here's where it gets tricky, is if your symptoms are primarily really Borrelia symptoms, Borrelia is a little trickier. If we look at, there was an unpublished study that was presented at the International Lyme Associated Disease Society meeting about, gosh, I think it's maybe 15 years ago. I mean, it was way back when, right? And it wasn't published, but it was still presented. And in the study, people had just Borrelia, meaning they didn't have co-infections at all. It was a pure Borrelia, okay? And what the researcher, Dr. Stricker from San Francisco, did is he put everyone on clarithromycin and Flagyl. And so that was a treatment, that was the kind of state-of-art treatment then to treat spirochete and intracellular Lyme and then cyst Lyme, okay? We did not know about persisters back then, okay? Anyhow, what he did is he put people on these 2 antibiotics and he watched to see what would happen. And by 3 months, 30% of people started having some improvements that they noticed. By 6 months, 60% started having some improvements that they noticed. And by 9 months, 90% started having some improvements they noticed, okay? So the take-home message I want you to know is even if you're on a good Borrelia treatment, it just may mean you need to stay on it longer before you start getting better, okay? All right. But having said that, in my own practice, if I've got somebody on a treatment and by 6 months, whether it is for Bartonella or whether it is for Borrelia, we're not starting to see improvements, then it's time to start thinking about how do I change my antibiotics, maybe 1 or 2 of those herbal or prescription antibiotics to something else to try to move the treatment along, okay? Secondly, we know that one of the things that blocks treatment in Bartonella and Borrelia is these biofilm slime layers, okay? So something to consider adding in at this point in treatment, if you're seeing no improvements, is a targeted biofilm disruptor. So Bartonella and Borrelia can have a slime layer that covers them. That's called a biofilm. These are really intricate substances though. So it's a mucus polysaccharide sugar slime that's held together in a protein skeleton made up of a blood clotting protein called fibrin. And within the slime, there are communities of non-tick-borne infection germs, bacteria that all carry out different functions. Like some of them operate like the post office, some of them are the sanitation department. There's tubes that run through these things that carry garbage out and bring nutrients in. I mean, these are really elaborate structures, okay? But you can do things to break it down. And there's two options. One I would probably start with would be to use lumbrokinase. Lumbrokinase is a group of enzymes that come from the skin of earthworms. I always get a kick out of what we have to resort to here in Lyme, but the skin of earthworms, and they break down fibrin, that protein skeleton that's holding your things together, okay? And the other advantage of using a lumbrokinase is, in addition to biofilms, when it comes to Bartonella, there's another thing that can block treatment. And that is, not only does Bartonella develop these slime layers that cover them, Bartonella also has the ability, independent of a biofilm, to wrap itself up in fibrin. And these fibrin germ nest stick on the blood vessel wall, and they kind of hide from the immune system too. And lumbrokinase breaks down that fibrin protein. Okay, so if you're getting no headway, there's a couple of things to consider. One is look at your herbal antibiotics and think about whether you want to maybe change those up a bit. Secondly, I would definitely look at adding in a lumbrokinase, which is usually going to come either as a 16 or a 20 milligram pill. And I would start at once a day. And after you go through a Herx from that, because you might want to advance that to twice a day. The difficulty with lumbrokinase, keep in mind, is that it is a digestive enzyme. So if you put other things in the stomach with it, in other words, if you eat with it or you take other supplements with it, it might try to digest those and not be available to break down your biofilm and your fiber nest, okay? So I'd like people to take 1 hour before they take their lumbrokinase. They should have an empty stomach, except water is okay, through an hour afterwards, all right? So taking lumbrokinase is tricky because you got to have an alarm system that's going to keep alarming you as to when you have to stop eating, when you take it, and then when you can resume taking other things again. All right, but those are things to consider. So Cecile, are you still here by chance? So Cecile may have just written this question and gone back to sleep, given how late it would be over in France right now. So Cecile, the only question I was going to have for you if you're listening to this tomorrow is, what herbal antibiotics are you on, so that I could kind of help give you an idea what you might want to shift to. Okay, all right. But unfortunately, I don't get that opportunity here. All right. All right. So Cindy, I see your hand up there. Is it a question relating to what we're just talking about here?
No, it's not.
Oh, it's a separate issue then?
It is a separate issue. I asked it up there. May I just ask you now that you've got me?
Sure, but I just want to say the one thing I don't want to. So everyone, I don't want everyone to start rushing in and adding your questions in. I'd rather work off the list, but I'll take a one-time exception for you here.
Well,
okay?
if you want to go off the list, I totally get that, and that's fine.
Okay. We'll go off the list then, just to be fair to everyone who wrote their questions. Okay.
Cool.
All right.
Cool.
All right, Cindy. Thank you.
Absolutely.
All right. Let's see here. Hello, Tracy. Let's see. Hi, Marty. Are you aware of any connection between tick-borne infections and thrombocythemia? If not, are there other causes or contributors you're aware of? Is there anything you can recommend that might help? So, Tracy, I just want to clarify what you mean by thrombocythemia. Do you mean thrombocytopenia?
No, thrombocythemia. Let me make sure that that's right, but I'm pretty
sure what that term means. I'm very familiar with thrombocytopenia, unless they're changing how they're using that term.
Let's see. Yeah, thrombocythemia, Cythemia.
Well, by golly, hold on here just a minute. I'm going to look that term up.
Stumped you.
I want to see if something has changed in medicine I'm not aware of. Thrombocythemia.
It's like too many platelets.
Oh, interesting. I haven't. So first of all, you can probably tell by my reaction that I'm not aware of this. So The issue is I've never seen a situation. Thank you. So you brought an issue to my attention. I've seen lots of thrombocytopenia, which is low platelets, but I have not seen thrombocythemia, which is excessive platelets. So I haven't seen that in tick-borne infections. Given how much I've treated, you would think if it was something caused by it, I would have seen somebody with it by now, basically. So that would be how
Right.
I answer that one for you. Okay. And then in terms of how to treat it, I don't know. I haven't, obviously, if I'm just learning the term, I don't know how to treat it. What are they suggesting for them?
Not much.
Okay.
It's just, and sometimes, when you go into other realms, people
Yeah.
have other ideas, but
Yeah.
it's usually sort of just watch and see, maybe some baby aspirin.
Yeah. Well, I am familiar with something called polycythemia, which is excessive red blood cells. And what we do for that is we literally just have somebody go and donate blood once a month or once every few months to lower the red blood cell load. But I'm not sure if that's what they do with thrombocythemia at all or not. Whether they
Okay.
just have a person go donate platelets, basically.
Right. Yeah, I just thought maybe there would be some kind of, integrative medicine
Yeah.
opportunity, but
Yeah, no, I haven't seen anything like that before. Yeah.
all right. Well, thank you anyway.
Yeah, thank you. All right. All right, let's see. Marcel Caesar, I think that's what your name is. Let's see. What are your thoughts on ozone and red light therapy after prolonged antibiotics and antifungal treatment for Lyme and positive urine fungal tests for a person who still has persistent fatigue? All right. So let's talk about red light therapy first, as I actually have more positive feelings about that than ozone, and then I'll talk about ozone for you. So red light therapy has benefit for mitochondrial function. It helps improve part of how your cell energy called ATP is made within your mitochondria. And so it can help with mitochondrial function, okay, which could give more energy. It also has some anti-inflammatory potential as well too. So it might, if you haven't done anything else for mitochondria support, and I'll talk more about that here in a minute, it might give you some benefit. It does have benefit in athletes that have inflammation, and it does have benefit in athletes who have mitochondrial issues as well too. That's where we know more from it. I don't have any data on people with tick-borne infections, but I don't see harm in giving it a try. Okay, all right. Ozone, on the other hand, ozone is a form of oxidative medicine. And there are people that sometimes advocate using it to kill germs, but I don't advocate it for that. And I'll try to explain why here in a minute. But the other thing that it can do is it can result in better oxygen delivery to your mitochondria, and it can help your mitochondria work better. So you'll sometimes hear stories of people that go and get their 8-10 pass ozone treatments, for instance, and they feel better. And the provider mistakenly says, oh, it's because we're killing your germs, right? But here's the issue, but with probably the reason it works, if we look at the science on it, it's probably because it helps your mitochondria work better. That's why they feel better. In terms of being a germ killer, one of the godfathers of advocating ozone treatment and oxidative medicine as a means of improving health and promoting health. I forget what his name is, but he went and did a research at one time, a project trying to see is ozone really a germ killer in the body? Okay, so yeah, I mean, ozone can kill germs on your skin surface, but in the body, in your blood, does it do anything? And so what he did is he took a test tube full of germs, put ozone in, and killed all the germs. Took the same germs and repeated it again, put a very small amount of blood, very small, and then put the ozone in, and there was no killing at all. None, no killing at all. All right. And what the issue is, your blood is loaded with antioxidants, and those antioxidants can partially neutralize the killing effect, neutralize this oxidative medicine. Antioxidants neutralize it. Okay. The only problem I have with people using prolonged ozone, like 8 treatments or more, is even though your antioxidants can keep up to a point, at a point, is it too much of an oxidizing agent that it starts damaging your cells, your proteins, the covering of your mitochondria, the what's called the electron transport chain that develops ATP in your mitochondria? Does it start damaging your DNA? So you've got to remember one of the big stressors in our body that leads to aging and cell compromise and organ compromise is oxidation. So I think we have to be careful about repeated uses of oxidative medicines like ozone, because we really have no studies that tell us how many times can you do it if you're using it on an ongoing basis before you damage yourself. Okay. I do think on a short-term basis, maybe a few treatments, it could result in better oxygenation to your mitochondria, and therefore that might be an okay thing to do. All right. All right. So Marcel, does that answer your question? Your question for you? Yeah. Oops, I need your microphone on there, Marcel.
Here it is. Yes,
There
thank
you
you.
go.
That answers my question.
Okay, very good. Good luck to you. All
Thanks.
right. Sandra, I see your hand up there. Hi, Sandra. Oh,
Sorry, I just got my phone's ringing and I can't turn it off.
did you have a question, Sandra? Oh, all right. All right, let's move on here, everyone.
I'm sorry, my phone was ringing and I couldn't turn it off. I was trying to get rid of the ringer.
Okay.
Um,
Did you have a
I-
question, a follow-up
I-
question to what we were talking about?
Yes, I do.
Okay.
Is hyperbaric oxygen, would that have the same effect as the ozone passes that you're talking about?
It would, but it gets a little trickier with hyperbaric oxygen because you're using pressure. It's high pressure oxygen, okay? And that pressure can result in a release of a greater number of what are known as stem cells in your body. And stem cells go and repair tissue, right? And so I think the jury is out. And also, you get better oxygen within your blood, so you have better oxygen levels to provide oxygen to your mitochondria. So I don't think we have long-term studies yet telling us whether repeated hyperbaric oxygen is, we think it may be good from an aging standpoint, mainly because of it just triggers the release of all these stem cells and can really boost up your mitochondria. But I'm not sure in Lyme, where we already have so much oxidation going on from having the germs in us, if it is a good idea. I honestly don't know. We do know there was a while back, about 15 years ago, where there was a move on within the world of Lyme disease where everyone was getting hyperbarics because we thought it might actually kill germs too. That oxygen may kill the germs. And what I'll tell you is most doctors that had bought those chambers and had them in their offices and hospital facilities that put them in to treat people with Lyme eventually just shut them down because we really didn't see benefits in the health of people living with Lyme.
Thank you. And sorry about the phone ringing at the
Oh,
same
you're
time
welcome.
as you asked
No
that.
problem, Sandra. No problem. All right. And then let's see here. I see a hand up from, I don't know, what does litening mean? Oh, turn your microphone on. I can't hear you.
Sorry about that.
Oh, no problem.
That's my email. My name's
Oh.
Catherine.
Okay. Hi, Catherine. Nice meeting you.
Hi. I did put a message over there about I had a positive test with Vibrant Wellness, and I know your opinion on that. Only my docs won't order the IGeneX test, so it is what it is. But I'm not herxing, and I got up to 30 drops on the Banderol and the Cemento mid-March.
Mm-hmm.
and still no herxing. And they really made a big deal. Like I have the Bartonella for herxing, never had to use it. The thing is, I did have a positive Western blot back in 2020, and I did herx then. The only thing is when I saw an infectious disease doctor, she said, because I had, and I have my test if you want me to read it, because it was my IgMs positive, not my IgGs.
Yeah.
She said she was positive I had only had it for less than a year, but my symptoms go back to 2001. I was just misdiagnosed with RA all that time.
So let me make, so I'm going to just make a small request here. So again, when I have people raise their hands, it's not to ask a new question, it's to ask a follow-up question to something we're already discussing at that moment.
I'm sorry.
Okay?
I did put my
Yeah.
thing up there.
So I'll get to you when I get to you then. Okay.
Oh, I'm sorry. I apologize. It's
No
only
problem.
second time. I'm a newbie.
Don't
Sorry.
worry, I'm not
Forget me.
upset. I'm just making sure that I'm fair to the other people here too. So yeah.
Sure.
But
No, I'm sorry.
we'll get to you. Okay. I hope we get to you.
Okay.
All right. Good. All right. All right. Let's see here. Lisa. Hi, Dr. Ross. My daughter is on your Babesia protocol and has folded in the lumbar kinase. She is passing a lot of biofilm in her stool. Would you expect to see that? Is that more indicative of yeast or parasites? Thank you. So, I would not, Lisa, I wouldn't expect to see slime, biofilm, mucus layers within your stool from killing Babesia, okay, or removing Babesia biofilms. But I can tell you that I don't know exactly what you're seeing, and I know there's something that looks biofilmy. So in theory, if it is biofilm, because it could just be mucus that's coming out for some reason as well too. But if it is biofilm, I don't think it would be Babesia related. We don't think Babesia lives in the intestinal tract, but it could be that she's got some yeast in there, or she's got some fungus in there, or parasites in there that have biofilm covering them, and it is breaking down that biofilm. That is possible. All right. Okay, good. Any follow-up questions to that?
I just wanted to say thank you. That's kind of what I thought.
Yeah.
And yeah, because she was treated extensively for parasites in the past, but
Yeah.
Maybe they're still present.
But it also could just be yeast accumulation, the
Okay.
pressure of being on things that are treating her Babesia, those may be lowering. So keep in mind that our intestines are made up of bacteria, viruses, parasites, worms. I mean, there's stuff that lives there that's healthy, right? So
Right.
even the pressure of being on the antiparasitics to treat her Babesia may be also eliminating some healthy parasites and their biofilm within the intestines as well too. So yeah.
Okay.
All right.
All right. Thank you and happy birthday.
It's still early. It's 2 weeks away. I spoke too early, but anyhow. Thank you. All right. Hello, Mary. Let's see. Hi, Dr. Ross. I recently had Radiance Diagnostic COVID long hauler panel performed. It does not show long haul COVID, but VEGF is elevated at 76.9. Interferon gamma is low. SCD40L is high. Immunoglobulins, G and M are slightly low. I'm going to add low dose LDN to my regimen. Everything is very stirred up after taking lumbar kinase 1 tablet a day for 4 months. I had to stop the lumbar kinase because I was so ill. How beneficial do you think the low dose LDN will be for me? So Mary, one of the things that so low dose naltrexone, everyone, is a compounded medicine that a pharmacy would have to mix up for you. This drug called naltrexone is made as a manufacturer's 50 milligram pill, but when we use it as low dose naltrexone, you start at 1.5 milligrams a day, and after 2 weeks, you go up to 3 milligrams a day, and then you go up to 4.5 milligrams a day. And what this medicine that's designed to help treat addictions can do in somebody with tick-borne infections is it can balance your immune system. And specifically, what we think it does is there's a there's a group of cells. You all may have heard of something called Th1 inflammation, Th2 inflammation, Th17 inflammation, and then another group of cells called T regulatory cells. And let me just explain this real quick. So when you have Th1 inflammation, it means that your cells that fight infection, those are called Th1. They're the cells that get in there, like your T cells and your macrophages that get in there and eat up germs, okay? If that gets too turned on, that leads to a lot of excess cytokines on the Th1 side, all right? Th2 is made up of your antibody producing cells and your mast cells. That's predominantly what makes up Th2. So if your allergy system gets turned on, or if your body keeps making a lot of antibodies because it can't get rid of an infection and the Th2 gets turned on, you have too many cytokines coming out of that, okay? Th17 are the groups of immune cells that sit right underneath our skin and our mucous membranes. And what their job is to do is to identify invaders that have never invaded our body before. In other words, we have no immune system memory of these germs. They're the frontline defense against those, all right? And what we think in autoimmune illnesses is that Th1 and Th17 get too turned on and they don't know how to turn off, all right? Now, so their cytokine patterns from those cells just stay revved up and you just are chronically inflamed because of that, okay? All right. So the way you get balance between Th1, Th2, Th17, the way you get them so that the Th1, Th17 knock it down a little bit, Th2 comes up and performs better, is you got to work with the parent in the room. Right. And the parent in the room are called T regulatory cells. And they send out signals that try to get Th1 at the right level, Th2 at the right level, and Th17 at the right level. So one of the ways to increase your T regulatory cells and their governance of the immune system and their ability to balance the immune system is using low dose naltrexone. All right. Now, the one thing about low dose naltrexone is for most people, it's very well tolerated. Side effects that sometimes develop are insomnia. Sometimes people have more confusion being on it. Those are the two big ones. And occasionally abdominal pains or nausea from being on it, okay? But usually when I start a person, I start at 1.5 milligrams. And I have them take it in the morning, not at night. I have them take it in the morning so that we don't run into the insomnia issue. But there's an occasional person that 1.5 milligrams is too much. And so sometimes I'll go down to 0.5 milligrams. So you try to, by hunting and pecking, you try to find the dose that you tolerate. Most people can start at 1.5 milligrams and do fine. The other thing I learned from a lot of my colleagues that use this is you need to use it for a minimum of 6 months before you see if there's any benefit from it as well too. Okay. So Mary, I think I could see, given that how difficult, I think it's a good idea, especially given all the excess Herx reactions you seem to get from when you do new drugs that kill germs, or you go up on the dose, or you expose them more by removing biofilm with lumbar kinase and remove fibrin nests by using lumbar kinase. Yeah, I think that makes some sense. The other thing that I sometimes will use if I don't want to use LDN is there's a peptide, a couple peptide regulators of your thymus gland that can get the thymus gland to release chemicals that cause more Treg cells. And that would be, it's a product by Integrated Peptides. It's called alpha thymogen or thymogen. I'm blanking. We'll look at it here in a minute. It's called Thymogen Alpha 1, I think is what it's called. And that has bioregulator peptides in it that also potentially could adjust up that Tregs. I wouldn't start a person on both at the same time if they're having a lot of inflammation problems. I'd start with one or the other and see how they handle it first, and then maybe add the second one in. If you do the Thymogen Alpha 1, I would do that at 1 pill a day first. And after a week or so, see if you can go up to 1 pill twice a day on that one. Okay. All right.
Okay.
Any questions there, Mary?
Thank you. No, just, trying to get through it all.
I know. I understand. Good luck.
It's not easy.
Good
It's
luck.
not easy.
I'm just
All
going
right.
to do a quick screen share here for everyone. So in terms of this product, the Thymogen Alpha one I was telling you about, this is the integrative peptides product, okay? And it's got 2 thymus bioregulators in it. Bioregulators are very small peptides, usually about 1 or 2 amino acids in a peptide. And they literally try to direct the organ that they regulate what to do, basically. Okay, all right. And this has got 2 bioregulators in it. And then in terms of the article, I have an article on this whole T regulator thing, and it's called Boost T Regs to Balance TH1, TH2, and TH17, where I explain what I just said to Mary. I have a little bit more of an explanation in here, but this would be the article to go ahead and look at on that one too. Okay.
Okay.
Yeah.
All right. Thank you.
You're welcome. Good luck.
Thank you.
Let's see. Tracy, could lumbar kinase or nattokinase contribute in any way to ligament laxity, joint dislocation, or a meniscal tear? So I don't think lumbar kinase would, because it is a pure fibrin olytic, meaning fibrin protein, not all proteins. Okay. And nattokinase off the top of my head, I think is strictly a fibrinolytic, but I would have to look that one up a little bit more. I would have to see if nattokinase has more works against other proteins other than fibrin. And off the top of my head, I don't know that one. Okay.
What proteins would you, like if I wanted to look that up, what would I be looking for?
I would say, what proteins does nattokinase destroy?
Okay. And then I have to see if they match the proteins that are in ligaments and.
Which the main one would be collagen. Yeah.
Okay.
Yeah. Yeah.
Okay. All right.
Okay. All right.
Thanks.
Yeah. All right. Let's see here. Get rid of that. Hello, Chris again. Let's see. Hi again. If the main and seemingly only symptom is heavy brain fog, cognitive issues of my Lyme Bart, is your approach protocol the same? Yeah. Yeah. Again, yes, I would. In terms of my Bartonella approach, it would be the same. Bartonella has slightly different presentations in people, but if that's what's causing your symptoms, the approach is still the same. Yeah. Okay.
Easy enough. Thank you.
Yeah. Yeah. Good luck. All right. Let's see. Katie Yule, Dr. Marty Ross, what are your thoughts on my unique pulsing protocol that has unique pulsing protocol that has 2 protocols. Been on antibiotics and ivermectin 9 weeks, and during the time had 10 days, 3 times where I felt almost well. I then added Arcoda and Malarone, and I am so in a lot of pain. I can't handle the Arcoda every 7 days, and have gone 7, 14, 10, and 17 days in such a herx of my only symptom I feel, which is esophagus pain and inflammation. I am afraid I'm going to cause resistance with the Arcoda. Is it okay to spread it out like I am? Is there anything I can do to calm my immune system down? Okay, so let me just say, when it comes to treating Babesia, I don't like to pulse except for with artemisinin. Except you have to understand something about Arcoda. So Arcoda, when you take it, most of us will have people take it once a week, which I know on the surface looks like we're pulsing, but just hear me out. Arcoda has an extremely long elimination half-life, meaning the time it takes for that pill you take to get out of your body is near, I think it's 2 or 3 weeks, if I'm right. But let me look it up here real quick. But things that take a long time to get out of our body don't need to be dosed that often, because we have a constant drug level in us, basically. Okay. So when I first started using Arcoda in my practice, because of the long half-life, I was only giving it to a person every 2 weeks. All right. But I think every week is fine. I would work with your provider to find a regimen that's not clobbering you. Maybe it's going to be every 10 days for you. Okay. And again, the issue with our coda is it's got this very long elimination half-life. And let me look it up. I'm going to try to tell you how long it is here. Oh, come on. Well, that's not working. My handheld device isn't working. I'm just going to do a quick look here online here. Yeah, okay. So the half-life of our coda is 14 days, all right? And for a drug to get completely out of you is 4 half-lives. So that one pill that you take 2 weeks later is still half in you, and it would literally take 2 months for that pill that you took to be completely out of your system. So when things are removed that slowly, we dose them at once a week or once every 2 weeks. Okay. All right. Did that help you, Katie? Well, let's move on here then.
Oh, sorry. Yes, it does help me.
Okay.
So it could be okay to be doing for every 14 days. I just need to talk to my doctor about,
Yes,
could it be longer than 14 days?
it could be just because of how long, again, this stuff is in you for 2 months, to some degree, right? And what you're
Mhm.
trying to find is what's the dose that still moves you forward but doesn't clobber you, basically.
Okay, got it. Now, I sent you my protocol A, protocol B. It's very unique. I've never seen anybody do anything like it. I'm going to shut my door.
Yeah.
Um, but it's 7 days on protocol A, 7 days on protocol B, just back and forth, back and forth. And it looks, I mean, like a Bartonella protocol, really. Have
Yeah.
you seen anything like that?
No. I don't understand why your provider is doing this. In my Bartonella protocol, so Bartonella and Babesia replicate every 24 hours. So they replicate fast. So in the days, except for like Arcoda, which is always in you practically, but the other drugs, on the days that you're not on it, is allowing the germ to replicate and come back. I also don't understand why providers use ivermectin. Ivermectin has the ability to kill parasites. That's what the science tells us. Some doctors think it kills COVID, and I think the science on that is very questionable, actually. There is no science that tells us it does anything against a tick-borne infection. In other words, no one has ever done a study that tells us whether it kills tick-borne infections. And there is nothing in a mechanism of action that would suggest to me that it kills tick-borne infections either. Now, it is a strong anti-cytokine agent, so sometimes people can feel better when they're on it. But in terms of a germ killer, I don't understand. So in other words, this is diametrically opposed to how I would treat all of your infections. And I'm not in your provider's mind to understand what their rationale is. All right. Now, having said that, I acknowledge I have my way. We have no studies that tell us what is the best way, but to me, this just doesn't make sense.
Okay. And if you were to say take a break because you're just herxing too much,
Yeah.
but you don't want to do that too long because Bartonella grows back so fast, how
Yeah.
long is the max you would say a patient should take a break from medicine?
So Borrelia, if you are just treating Borrelia, it's okay to take a 4 to 8 week break because it replicates so slowly. For Bartonella and Babesia, I really advocate against taking breaks because the germs are going to come back. What I would rather do in those situations is to decrease the dosing of the antimicrobials, the strength of the antimicrobials, so that I'm not clobbering somebody quite as bad.
Okay, that makes sense.
All
Okay,
right.
thank you so much.
Yeah. Yeah. Good luck to you.
Thank you.
All right. Let's see here. Cindy, let's see. Having trouble detoxing, so my doctor urged me to do the DNRS program for the limbic system. Just began and wondering what you think about it. So Cindy, it depends on what is happening when you're detoxing. So there is what the limbic system does is it governs a lot of things. It's like our flight or fight response. It governs our reproductive tendencies, okay? And it is part of our brain that kind of puts us into overdrive. It is the system that sits on top of your adrenaline, anti-adrenaline systems.
Yeah.
And if it becomes too turned on, our bodies, through the adrenaline, anti-adrenaline system, become very reactive very easily. In other words, it could be a smell that we smell, or we start having some sense that we don't feel quite right on the agent that we're taking to detox, and it triggers this whole adrenaline limbic system on auto drive reaction that makes everything that's happening to us 20 times worse than it might be if we were not having that limbic system on auto drive reactivity. Okay. So,
Yeah.
all right. So, in situations like that, retraining your limbic system using a DNRS or using another program called Primal Trust or using another program called the Gupta method, any of those are programs that help to calm that agitated limbic system down. Okay. So what it may be, and I don't have a chance to go into this specifically with you, but if it is that your provider is just thinking that the amount of symptoms you're having are way more an extreme than they might expect for what they're doing for you, there is a chance that this is a brain reactivity on auto drive, and they're trying to affect that basically. Okay.
And that is what happened. I couldn't detox any of the combinations of herbal and antibiotics. Never could detox any of that. I would always get much more worse, like a herb.
Yeah.
And he said, he stopped all the protocol. And said, please do the DNRS and see. Because that is what happened. I became really sensitive to smells, different things.
And it really may be, there may be both a physiologic component to that as well as a limbic system component. And what he's trying to do is see if he can tease out the limbic system overdrive component on that.
Yeah. Okay. Thank you.
Yeah.
And thank you for always explaining everything in so much easier terms for us lay people.
You're welcome.
I so appreciate that.
I enjoy doing it. I call myself the chief explainer of all this stuff. So
you're so good at it. You're so good. Thank you.
I appreciate that, Cindy. Thank you. All right. Let's see here. All right. Hello, T. Let's see. Is it true yeast in the gut takes a long time to get rid of? How long are we talking about? Just diagnosis surprises. I don't have a female yeast infection, thinking it might be causing MCA, mast cell activation symptoms. Yes. So, yes, it is true. If you get too many yeast in your gut, that it triggers the mast cells that line the gut, and then you trigger this whole mast cell activation symptom. Okay, so keep in mind, your 60 to 70%. 60% of your immune cells in the body line the intestinal tract, all right, of which some of those immune cells are mast cells. And if the yeast that is infecting your gut triggers some of the cells that line the intestines to pull apart, you get small yeast parts that leak through, hit some of these immune cells, and trigger the mast cells to activate. So yes, you can have mast cell activation, which looks like in a lot of people food sensitivities from having intestinal yeast overgrowth. Okay. All right. Now, intestinal yeast overgrowth, it depends on what you're going to use to get rid of it. If you're going to do herbs along with probiotics, along with prebiotics and polyphenols, herbal antifungals, and I'll say more about why I'm saying polyphenols and prebiotics and all that. But if you're doing an herbal antibiotic or anti-yeast regimen, it's going to take about 2 months, and the herbal antibiotic regimens, or not antibiotic, antifungal regimens work about 80% to 85% of the time over 2 months, okay? But you also have to be putting probiotics in, and you either through your diet or through supplements need to feed the good bacteria with prebiotic fibers and polyphenols. All right, so polyphenols are colorful agents that you find in colorful food, vegetables, and colorful fruits. All right, so if your diet is rich in a lot of color and it's primarily plant-based, you don't need to take polyphenols because you're getting them from your diet. But if not, you want to take a polyphenol booster, and you want to take at least 1 pill once a day, maybe 2 pills once a day. All right. And if your diet is not rich in a lot of plants, then you're not getting prebiotic fibers that feed your healthy bacteria, and you would want to supplement a prebiotic. And a prebiotic, there's a product we carry called Mega Pre that is a very good prebiotic. And the product for the polyphenols is called Polyphenol Booster. Okay, so when you have too many yeast in the intestines, it is not just about killing them. You have to support the good bacteria to take over territory from those yeast, okay? So you need to do polyphenols, you need prebiotics either through diet or through supplements. And then finally, you want to be on a good probiotic. And in situations like this, I'd like to use a probiotic that has Akkermansia in it, as well as some other bacteria that lead to greater production of butyrate in the intestines. Butyrate heals those leaky cells that I was telling you about. And the product I like for that is a product called, I'll show it to you here in a minute. All right. Second thing, okay, so you could do it with an herbal anti-yeast medication. All right. That's going to be 2 months as long as you're doing all the other stuff. All right. Or you could do a combination of prescription diflucan, 200 milligrams once a day, nystatin, 2 pills twice a day, along with the same probiotic, with a polyphenol and prebiotics, and you would be done in a month. And that works about 90% of the time. Okay. All right. Now I'm going to just do a quick screen share here because I don't like that I'm blanking on the name of this probiotic I want to tell you about. All right. So let's go here. Oops, wrong one. I'm showing up that way. Here. What are we doing? All right, so what I would do is this one called Metabolic Daily, okay? Because the bacteria in here not only repopulate your intestine and promote good bacteria in the intestines, they get your intestines to start making more butyrate that heals the cells lining the intestines, okay? And then again, I would do the prebiotic and the polyphenols as well too, all right? Then in terms of an article that I've written that tells you how long is it going to take with either the prescriptions or the herbals and which herbs and prescriptions to use, take a look at my article called Kills and Prevents Yeast, a Brief Guide, where I walk you through all of this if you want to have it in a written format as well too, okay?
Yes, very much. Thank you.
All right, good luck to you.
Thank you.
Yep. Right, let's see here. Maria. Hi, Dr. Ross. My daughter had mild illness in Bartonella. We remediated, and now she's having issues tolerating binders. She has tried cholestyramine and Welchol. Now I'm giving her chitosan. What do you think about this binder? She also has lots of new Bartonella striae showing up. Do I have to have her on certain doses of binders before starting your herbal protocol? All right. So, do you have any idea, Maria, what mold toxins she has in her?
Hi.
Hi.
I think she has awkward toxin.
Okay.
And there was one more. I forgot what it's called.
And
I
then
haven't done a urine test a long time ago because now I'm into doing like the shoemaker, you know, all the blood work.
yeah, yeah.
So
So
we're
well, I'll say something about shoemaker and blood work here in just a minute. But
okay.
what when you say she can't tolerate the CSM and the well call, what happens exactly?
Well, first of all, we started with cholestyramine and she was doing fine before we remediated, but after we remediated, she was having gut issues a lot.
Yeah.
Well call just knocks her out. I mean, she is like in bed for like 2 days, like but extreme fatigue, joint pain, head to toe, even
Yeah.
like brain fog. I mean, her symptoms are like a lot more. So
So what may be happening with the well call is it may be that the dose they're giving her is too much.
well, I gave her like just very tiny. I mean, I even did water well call.
Okay. It could still
Which is
be
weird.
that maybe that's just too
Okay.
potent of a binder for her.
Okay. Yeah.
Have you tried the chitosan at all then or not?
No, I haven't.
Okay.
Oh, I have. She's on day 2 of it. I've
Okay.
been giving her one like before meals.
Okay. Let me bear with me here. I have to look up microchitosan real quick.
Sure.
You know, I'm not. Let's look at something together here. So
Okay, great.
I am not familiar with that one having
Okay.
any ability to bind any toxin. I'm not saying it doesn't. I'm just
No,
not.
no, no, yeah.
So what I'll look at with you is a whole table I created about which binders work on which toxin. Okay. So if we go
Okay.
to my mold toxin article, and this is one of these things I pull out periodically and have to look at. Right here, I have this is a whole table I created, okay?
Okay.
And I don't even think they have chitosan on here. Yeah, so this is not one of, so what this table is based on is research that has been done looking at various binders to see what toxins.
What toxins? Okay.
Right? Yeah,
Yeah.
and I just don't see it there. Okay.
Okay.
And again, I don't know her full. I know you're remembering maybe 1 or 2 toxins.
Yeah, citrinin, that's another one that she had.
So she had citrinin. So one thing you might want to look at is I like working with a product called a GI
detox.
Yeah, GI detox.
Yeah, I have that too. I haven't tried it yet, but I mean I have everything, I think.
So it's broad spectrum. It's going to pick up a number, and I've worked with it enough to know that it works basically.
Okay, great.
You might want to look at that one as an option
Okay,
too.
great.
If she's too reactive to that, then the place that I like to go, and even though it's not on that table, I've had success in my practice, is I like to use citrus pectin. So citrus pectin generally tends to be the easiest thing on the gut, tends not to lead to constipation, and tends to be more of a mild mold toxin binder. Okay. And I mentioned that article that I just showed you, I mentioned my thoughts on citrus pectin, even though it's not in the table. Okay. And I talk about how to use it there too. Okay.
Okay, perfect.
Yeah.
Thank you.
Oh, and then, you can add in your treatment for Bartonella anytime.
Yeah, she doesn't have to be on like full binders or something like that.
Nope.
Okay. Because I just see the stretch marks are like,
yeah,
I start getting more and more.
Yeah, so I will treat both mold toxicity and infections simultaneously at the same time. Yep.
Okay, great. Thank you so much. I appreciate it.
Yeah, good luck.
Thank you.
Cecilia, let's see. Hi, is it okay to use Pectisol to treat mold? Yeah, that's what we were just talking about. Pectinisol, I think you actually mean Pectisol is pectin, modified citrus pectin. So yeah, definitely so. It's one of the more mild, does not disturb your intestines binders, basically. Okay. All right. All right. Guess where we are here. I think it's Catherine. Is that right? Is that who LITNG is? Am I remembering that correctly?
Yeah, that was my email.
But it's Catherine's your name, right?
Yes, yeah. My email was associated with my Zoom account, so I'm sorry.
No, it's okay. I was trying to remember your first name, so I am remembering it correctly then.
You
Good.
can call me anything you want.
No,
I'm
I'm
just
not
so
gonna,
happy to be here. I've
not
learned
gonna do
so
that.
much. I've
All
learned
right,
a lot from your
let's-
website.
So it's your question. Let's go ahead and look at this. Okay. So I see I had a positive vibrant test January 24th.
Can I ask you one thing?
Yeah.
Real quick.
Yep.
Because I have looked into mold. I've looked into everything. You were going to say a little bit about Richie Shoemaker.
Oh, okay. So yeah, I meant to, let me go there and then we'll come to the rest of your question. Okay. So,
Sure.
Dr. Richie Shoemaker is the doctor that first described mold toxicity. Okay. And in a lot of us have moved beyond him. I'm just going to start by saying, especially those of us that treat tick-borne infections. All right. So Richie Shoemaker, first of all, does not believe in tick-borne infections. He used to be a member of ILADS like 15, 20 years ago, and he just split off, and he's now got his head in the sand about the chronicity of tick-borne infections. So the problem I have with many people that manage mold toxicity using his protocols is they don't test to see if you have mold toxins in you by doing urine testing. All right. All that they rely on is a bunch of biomarkers that he tests, like VEGF, like TGF beta 1, like C4A complement, C3A complement. There's a whole bunch of them. Okay. And what my point is those are biomarkers. And if they are elevated or they're low, it may not be that mold toxicity is causing that problem, because a lot of those same biomarkers will be off when you have chronic tick-borne infections, which he refuses to acknowledge exist. Okay, so when you have chronic tick-borne infections, his biomarkers are worthless because they really may be wrong or off their normal range because of the tick-borne infection and the immune reaction to that. Okay, so that's I meant to say that to the last person we were talking to. I don't trust it. Okay, and so I like looking to see if there evidence that you have mold toxins in you. And unfortunately, the best way, it's not perfect, but the best way we have to do that is urine mycotoxin testing. Okay, that says if you're peeing out a lot of mold toxins, it's in you. And the other thing I want to let you know is a lot of what Shoemaker will say is, well, that stuff is coming from your food. That's why you're peeing it out. One of the labs that does mold toxin testing did is they did an experiment where they had people eat foods high in mold toxins. They knew they had mold toxins in them. And then they went back and redid the urine testing to see, was it of enough of a range that it showed up as a positive on their test? And the answer is no, because the amount you get from even heavily moldy food is so minuscule relative to what they say you need to be diagnosed with mold toxicity. Okay, so just want to let you know it's Mosaic Diagnostics that did that test. Okay, all right. So
Thank you.
Yeah, you're welcome. Okay, let's see. I'm on. Okay, so you have Borrelia. I always fuck up the speech on this one. Myoni, I think is how you say that one.
Yeah, I don't know the correct one either.
Yeah, I think it may be myomoti is what you actually mean, but anyhow, it's not going to change my response though. I'm on Banderol Cemento, got up to 30 drops twice a day, March 15th. I have not had Herxed yet, and the PA made a big deal about Herxing. Let's see, I had Western blot in 2020. I did Herx during my month on Doxy that. I'm wondering if I really have Lyme now. Mast cell activation syndrome ruled out. I saw the clip done by Dr. Kerry Mullis, inventor of the PCR test, where he said PCR picks up fragments of whatever is in our body and just amplifies it. Just because something is in our body and PCR picks it up doesn't mean we can say it's an infection. So, since I haven't Herxed, could this be the situation? The ID doc I saw in 2020 said because my IgMs were positive but not IgGs, so that 2020 infection was not a chronic infection, and said I only had it for less than a year. My symptoms started 24 years ago in 2001. I was misdiagnosed with rheumatoid arthritis 2005 to 6, so my symptoms predated this. Positive Western blot in 2020. Do I have Lyme or need a new protocol? Okay, there's a lot to unpack there, and I will. All right, so and we have
Sorry, a lot.
No, don't worry. I can get this done in 5 minutes too. All right. So number one, The NIH, okay, let me start by saying this. Based on research that was done at the NIH about 20 years ago now, we know that 50% of people that have been treated for chronic Lyme with antibiotics that failed treatment continue to have positive IgM antibodies. Right. And the reason we know that is back about 20 years ago, the NIH ran 3 studies trying to see, does long-term antibiotics, IV antibiotics, improve the status of people that failed previous treatments, all right? And based on their interpretation of their studies, they say, no, prolonged antibiotics didn't work. Based upon ILAD's interpretation of the data, we think 2 of the studies did show they work. Anyhow, that's a whole nother issue, okay? But to enroll in the study, you had to have been documented as having Lyme in the past, you had to have been treated, and you had to have failed. And then to get into the study, you still needed to test positive on a Western blot. And for people, so in the data, if you break the data apart, 50% of those people that had been treated adequately still were making IgMs, okay? All right, so, traditionally, we think that IgM antibodies are supposed to go away by about 6 weeks to 3 months, and they're supposed to get replaced by IgGs. It appears that that does not always happen in chronic Lyme disease, and we don't know why. Okay, now so a positive IgM does not mean you had acute infection. It does if you actually did have an acute infection. That would be the thing that would have gone positive first. But in chronic Lyme, in 50% of people, they can still hang around. Okay, now IGeneX has developed this new test, a newer test called an immunoblot. It's a method of looking to see, does your immune system make antibodies that attach to the germ? And what they do is they take the proteins from Lyme and they grow them in bacteria, but they modify these proteins to clean out amino acid parts that might hold on to antibodies made against viruses. Okay, so one thing that can make an IgM positive is if you happen to have HHV6 virus or Epstein-Barr virus. Some of these viruses cause antibodies to be made that will attach to IgM antibodies unless we modify the proteins that we're testing against. Okay, so if your so back then, it is possible when you had this original Western blot done that it's a false positive. It's possible just because it wasn't using cleaned up proteins. There's a chance it could be positive because of viruses, okay? But these days, if you get an IgM that's positive even years down the road and it's an immunoblot, it's real. That is not a false test at all, okay? So I want you to know that, okay? So I disagree with your infectious disease doctor on that, okay? All right, and that's based upon NIH data, basically, okay? All right, then let's see here. In terms of herxing, in my experience, about 90% of people herx during treatment. And it's true, that is a clue that you're on something that's working, okay? But I will also tell you 10% of people go through treatment and never herx and they still get better. Now, having said that, usually if you are a person that herxes when you're on something that worked, you often will also herx on other things that are working, okay? So with the Banderol Cemento, it is possible they're not effective for you because we know you're a person that can herx, right? Now,
Yes.
It would suggest to me, especially if you're not getting any better, that the Banderol Cemento may not be it for you, okay? So what I would suggest that you might want to bring up with your PA is possibly using Cryptolepis and possibly combining that with the cinnamon, clove, oregano essentials that I talked about earlier. The reason is those are proving, I mean, they're pretty potent when it comes to killing, growing, and persisting Lyme. And the other advantage is that oils also break up biofilm. So I tend to find it a bit more potent these days than the Banderol Cemento. And so you might want to look at building a treatment around that.
I was thinking also maybe because I live by your website. I really do. I love it. I thank you. I can see I'm an RN. I haven't worked for years because I've been sick, but I can see the passion that you have
Oh yeah.
for it, the science,
Yeah.
and I'm just inspired. But and I was going to see if that one protocol had the cemento, the Japanese knotweed.
Mhm.
Booner talks about green dragon, and
Yeah.
I was going to get your product, the liposomic cinnamon,
Yeah.
clove, and oregano.
So the one thing, Buhner died, I think, a little over a year ago now, and his books were written at a time that we did not know about persisters. Buhner did not know about persisters when he wrote those books. Okay, it's not to say that some of his protocols didn't deal with persisters. So, for instance, cat's claw, which is in your cemento, it can, in laboratory experiments, kill growing and persisters. But I think most of us now know that probably there's stronger herbs to deal with both growing and these hibernating persisters. And so it's possible if Buhner were around now and he saw the experiments that were done at Johns Hopkins, because he liked to base a lot of his stuff on his interpretation of science, it might be he'd be recommending something similar too. So keep in mind, when you look at his books, they're out of date. They're out of date because he's a master herbalist, don't get me wrong. He's got some good stuff,
Yeah.
but he was not aware of these things called persisters when he wrote. Okay. Yeah.
I'm sorry. Do you have time for one question?
Sure.
You had brought up ozone.
Yeah.
So you and I are the same age. So you might remember what's his name? Cat scratch fever guy, Ted Nugent.
Oh yeah, yeah.
His wife is really big into they lived in a mold infested house.
Yeah.
I only found this out because the contractor came to our house. We had a leaky roof.
Yeah.
And I was so worried about the because I already have Lyme, and I'm like, oh my God, I can't have moldy house. And he talked about ozone generators.
Yeah.
Are you familiar? Any feedback on that?
Yeah. So ozone, even though I said in blood, it gets neutralized by antioxidants in the blood, actually on surfaces like our skin and on wood products, it could kill. All right. Now, as to whether it's going to be able to kill deeply enough into the wood that has mold in it, probably not. Because, the mold isn't just on the surface. These little tentacles from the mold start invading deeper into the wood. So I don't think that ozone is going, if you've got mold in your house, you need to remediate by removing the structures that have mold. That is the only way to get the stuff out. You're not going to be able to get deep enough with your ozone gassing, if you will, that will effectively get rid of all of your mold. It will not be effective enough.
Okay.
Yeah.
Great. So thank you so much.
You're welcome.
I really appreciate it.
All right, everyone, that's it for tonight. So again, I'll be with you next week, but we're going to go on Wednesday, and I'll try to send out a couple announcements before next week because I know that's going to be confusing. The reason I'm doing that is one of my dear friends is coming in, and that's the only time we can get together. That's the only night he's available. So I wanted to have a chance to see him. So it'll be next Wednesday at 6 p.m. will be our next webinar. And I enjoyed seeing you all again. And again, I'm back. I know that I've been a little absent here just because of outside commitments, but no speaking engagements until September. So that's good. And I'm just glad to be off the road here and done traveling. So it's good. All right. All right. Good night, everyone.
Yeah. Good night.
Thank you.
You're welcome.